Healthy human movement relies on muscle synergies. These are cooperative patterns where different muscle groups are coordinated by the brain to perform a single fluid action. A stroke damages the nerve pathways that transmit these signals, interrupting the motor cortex's communication with the peripheral muscular system. In the immediate aftermath, isolated muscles weaken. Without central coordination, surviving synergies fire in isolation, resulting in abnormal and erratic movement patterns. Historically, clinicians viewed these jerky, atypical muscle spasms as a regression. Most treatments focused on inhibiting these movements to prevent them from interfering with standard rehabilitation. This loss of the brain's coordination leaves the muscular system isolated. The body's own reflexes become disconnected from conscious intent, creating a state of involuntary motor output. In the 1960s, Swedish physical and occupational therapist Signe Brunnstrom introduced a different perspective on stroke rehabilitation. She proposed that primitive, involuntary, and spastic movements are a necessary progression toward regaining full motor control. The Brunnstrom Approach teaches patients to utilize these abnormal synergy patterns as a tool for recovery, rather than treating them as symptoms to be suppressed. This chart tracks that recovery across 7 distinct stages. The x-axis represents the timeline of recovery, while the y-axis measures the intensity of the physical response. We monitor 2 specific forces: the presence of primitive spasticity and the return of complex voluntary motor control. This framework guides the nervous system through a structured clinical progression of healing. Stage 1 is the period of neurological shock immediately following the stroke, characterized by flaccid paralysis. While the brain may still be capable of initiating movement, nerve damage blocks those signals from reaching the affected side of the body. This loss of muscle tone, known as hypotonia, causes profound weakness and can lead to numbness in the limbs. On our recovery timeline, Stage 1 shows a total lack of motor output. Both voluntary control and spasticity remain flatlined at 0. If hypotonia is left untreated, the unused muscles will quickly begin to atrophy. Muscles require regular activation to retain their definition and tone. Because flaccid paralysis prevents active work, the limbs must be manually stimulated. Clinicians must manually sustain the muscular system during this window to preserve physical viability for future neurological reconnection. Stage 2 involves the initial appearance of spasticity, which serves as a sign of early neurological development and cell regrowth. As certain muscles are stimulated, the spasticity curve begins to slope upward, while voluntary control remains at 0. This stage triggers the flexor synergy, external rotation of the shoulder, elbow flexion, and forearm supination. The corresponding extensor synergy includes internal shoulder rotation, elbow extension, and forearm pronation. These synergies link muscles together. Activating one muscle in the chain forces a partial or complete response in the others, limiting the patient's range of motion. Many survivors in this stage experience velocity-dependent spasticity, an abnormal increase in stretch reflexes that creates resistance to passive movement. These jerky, spastic movements indicate that neural pathways are attempting to reestablish connections. In Stage 3, muscle spasticity reaches its peak, resulting in unusually stiff or tight muscles. This occurs because damaged pathways in the brain and spinal cord lose the ability to restrict motor neurons, forcing the muscles into continuous contraction. This is the apex of involuntary movement. On the recovery model, the spasticity curve reaches its maximum point on the y-axis. Treatment at this stage focuses on passive range of motion, or PROM, exercises. In a PROM intervention, the therapist moves the patient's joints through their thresholds to maintain mobility without requiring active effort from the spastic muscles. Stage 4 marks a turning point where spastic muscle movement begins to decline. As the spasticity curve drops on our chart, the voluntary control curve finally breaks off the 0 line. The patient begins to regain limited control over their extremities. Therapy shifts to active assisted range of motion. The patient initiates the movement, but uses support from the therapist or gravity-assisted equipment to complete the motion. Once baseline control is established, the patient progresses to active range of motion exercises to build flexibility and endurance without physical assistance. Navigating the peak of spasticity allows the clinical focus to shift from preservation to active, strength-based rehabilitation. In Stage 5, spastic synergy patterns decline as movements become more coordinated and complex. The patient moves away from involuntary synergies toward deliberate, isolated joint movements. This signals the restoration of the sensory-motor loop, where thought-initiated motor signals respond accurately to sensory stimuli. At stage 6, spasticity disappears. Motor control is nearly restored, and abnormal movements cease. On the model, the voluntary control curve spikes upward, crossing over and dominating the falling spasticity curve. Stage 6 allows for complex, goal-directed actions like reaching and grasping that require minimal conscious attention. The primitive reflexes relied upon earlier in recovery are now superseded by top-down cortical commands. Stage 7 is the return of normal function, which is the final goal of the Brunnstrom approach. The patient regains full voluntary control, and synergy patterns return to a healthy baseline. The completed model shows the full transition. Spasticity is at 0, while voluntary control is at 100%, forming a clear inverse relationship over time. While these stages provide the clinical framework, assistive devices and medical technology help facilitate the patient's progress along these curves. Stage 7 demonstrates that the neuromuscular disruption caused by a stroke is a traversable phase of healing. Signe Brunnstrom provided a new clinical understanding of how the body recovers motor function after a stroke. She demonstrated that spasticity serves as a functional indicator of neurological healing, rather than a permanent obstacle. A fully recovered neuromuscular system represents a beautifully complex coordination of neural signals, accurately responding to the surrounding environment. By utilizing the body's primitive responses as a foundation for recovery, the Brunnstrom framework provides a method for rebuilding functional independence.